My name is Abby and I am the president of the University of Leicester Radiology Society, and I'm going to be doing a teaching session on upper limb and C-spine imaging. And we also have Dr. Mohsin Hussain here as well. I don't know if he wants to introduce himself.
Oh yeah, I'm Mohsin Hussain. I'm one of the consultant radiologists in Leicester, and I specialize in musculoskeletal imaging.
So this is the content of what we're going to be going through in this session. So firstly, we're just going to have a look at how to interpret upper limb and C-spine imaging, and we'll be going through sort of the individual anatomical areas with the upper limb. And then we've got a couple of cases, around 8 cases, and then Dr. Hussein's added on a wee bonus case at the end, and then we've got our references things as well. So first of all, when we're looking at interpreting MSK sort of X-rays in general, we always want to make sure that we're doing it systematically. So one way that we do that is by following the ABCs, which allows us to make sure that we're covering all parts of it as well. So first of all, it's really important to make sure that the images that you've got in front of you are the correct patient. Because the last thing you want to be doing is reviewing an X-ray and it's of a different patient. So you want to make sure you've got the correct patient details on the radiograph, that name, date of birth, hospital number, and compare it with the notes that you've got in front of you as well. You also want to make sure that the correct imaging has taken place as well, so you've got the correct side. So by looking at the markers that we put on X-rays when we take them, to make sure that the left is the left, the right is the right, and also to make sure that the images haven't been flipped as well, because sometimes that can happen with the machinery that we use. And also that the correct views have been taken too. And it's also really important to note the date and the time of the imaging to make sure that the imaging you have in front of you is the most recent one. That also allows you to ensure that you're comparing it with past imaging that they have had as well, and that you're not looking at old imaging too. So when we're looking at A, we've got alignment and joints. So we're looking at any abnormal alignment, which could suggest things like fractures or subluxations or dislocations. And then also when you're describing displacement of these fractures or dislocations, you're looking at the position of the distal fragment or the joint when you're describing them in your interpretation. You also then want to look at B. So B stands for bones or bone texture. You want to look at any sort of altered bone density or any disrupted trabeculae patterns, which could suggest any underlying pathology, whether that be fracture or sort of metastases, tumour or infection, anything like that. And again, yeah, if we look at C standing for cortices specifically, you want to trace the bone cortices of all of the bones that you can see on that image to assess for any step or break, which could indicate a fracture or a pathology. And many common causes of bony destruction could be things like infection, such as osteomyelitis that may have spread from somebody who has had chronic cellulitis that's been untreated, or things like tumours, that could be primary tumour or a secondary tumour, for example, metastases. And then periosteal reaction as well. So that's newborn formation that you can see on an X-ray sometimes, not all the time, but you mostly can. And this can sometimes be the only sign that you might see of something like a stress fracture, but it can also indicate the healing of an old fracture as well. And then, yeah, looking for osteomyelitis and tumours. And then finally, but also very importantly, is looking for soft tissues. So we've got ABCs, so S being the soft tissues. So looking for any swelling, any effusion, any foreign bodies, and any incidental findings that you might see on the X-ray that you're looking at. So if we look specifically at the anatomical areas of the upper limb, starting with the shoulder. So you want to assess the glenohumeral joint for any dislocation. So you want to make sure that that head of that humerus is sitting and centered right in the glenoid. So on an AP view, if I get my pointer out, on an AP view like this one, you want to make sure that your humeral head is adjacent to the glenoid. And then on a Y view, which we haven't actually got here, but if you were to look at a Y view, it literally, the scapula looks like the letter Y. And you want to make sure that that humeral head is centered right over the glenoid. And often we try to get the humerus straight across that straight down the scapula. And then you want to make sure that you've got coracoclavicular alignment. And by checking that, you want to measure that there is a distance between the clavicle and the coracoid of around 13 millimeters. It can be 11 to 13. You want to make sure that the acromioclavicular joint as well is also aligned, that there's no step here or any widening. So the acromioclavicular distance is 8 millimeters, give or take, and you want to make sure that that isn't widened, because that could assess an issue with the ligament. You want to check the joint space as well to make sure that there's any narrowing or cartilage loss, which could indicate OA, so osteoarthritis. Any calcifications, any new bone formation such as osteophytes as well, or any subchondral sclerosis along the joint, again, common in osteoarthritis. Looking at B, so you're looking for common shoulder fractures of the bones, looking at the clavicle, the proximal humerus, And then looking at the cortices, which again is very important when you're looking for fractures, especially. So you're going to trace the line along every bone that you can see on an X-ray, assessing for any subtle fractures, any steps, any misalignment. And so you want to make sure that you're checking the humeral head, the neck, the shaft, looking at the clavicle, looking at the coracoid process and the glenoid, also looking at the scapular blade, which most of the time is okay to see, but when you're looking at the shadow of the lung, it can be a little bit more difficult. So make sure you're looking closely. And then also looking at the ribs as well. And then with the shoulder, it's quite important to look at soft tissues. So you're looking for any swelling, any asymmetry, any fat pad displacement, signs of joint effusion or calcifications. But most importantly, with the shoulder, it's always really important to assess beyond that shoulder joint as well. So, for example, looking at the ribs to see if there are any rib fractures, but also looking at that lung apex as well, because within that lung apex, you may see a pneumothorax that might be quite subtle, or a Pancoast tumor as well. So this image here is an AP, and then this one here is an axial image, which we often try to get, but in patients who have, say, a dislocation or sometimes a fracture of the humeral neck, it can be quite difficult because obviously it's very painful to try and get them to abduct their arm in that fashion. So now looking at elbows, again, starting with A's, so with the alignment and joints. So with regards to alignment, we want to make sure that this anterior humeral line intersects the middle third of the capitellum. So this here is the capitellum and the trochlea. Now on a lateral, they obviously superimpose themselves, especially if you get a good lateral. But you want to make sure that that anterior humeral line cuts across that capitellum. And then with the radiocapitellar line, you're going to draw a line in the radius and you're going to draw it straight across. And then that should point straight to the capitellum on all views as well. And the way that I remember it is that the radial head wears a cap. So you've got capitellum and then the radial head. Now you want to make sure that you're assessing that carrying angle. So the carrying angle of the elbow is that sort of slight outward tilt of the forearm from the upper arm. So you want to see that the lower arm is sort of tilting outwards a little bit when that elbow is fully extended. And it's usually around 5 to 15 degrees, and that allows the arms to sort of clear the hips when we're walking. And with females, they're generally larger, that angle is generally larger. So if you have an abnormal varus, which means the sort of arms are more inwardly sort of movement, so you've got the hands closer to the legs and the elbow sticking out a bit more, that's also known as a gunstock deformity or cubitus varus. And that's an inward angling of that forearm, and it often results if there's been a poorly healed supracondylar fracture of the humerus, which is quite common in children as well. You also want to assess the ulnus and radius alignment and consider some sort of fracture dislocations there as well, such as a Monteggia fracture, which is a proximal fracture of the proximal third of the ulna with also having a radial head dislocation as well. You want to just check on the AP that you've got, oh, sorry, my top has gone a bit funny, that you've got the radial head and the capitellum and the trochlea and the ulna are congruent with each other. So when you're looking at this AP, the radial head and the capitellum are congruent, so there's no displacement here. And then the same with that sort of the trochlea and the ulna as well. On the lateral, there should be nice smooth joint spaces, and you should have this figure of 8 appearance if it's a true lateral, which sometimes on patients who have come in with trauma of the elbow can often be quite difficult to obtain like a very true lateral of the elbow, because it requires us to abduct the arm quite significantly to be able to get that image. But sometimes we are able to get it. So you get that nice figure of 8 on a true lateral X-ray. And then you want to make sure that that radial head articulates with the capitellum and not with the trochlea, because that's not where it's meant to be. Looking at the bone texture, you're going to trace the cortical margins again and look carefully at the superimposed structures, the coronoid processes here as well, to see if there's any avulsion fractures along those lines. And yes, again, trace all of the cortices, look for any steps or breaks which can indicate a fracture pathology. Now, what's quite important with elbows, especially on a lateral elbow, is looking at soft tissues. So you want to assess for any joint effusions. So with a lateral elbow, we've got these things called the fat pads. You have an anterior and a posterior fat pad. Now, an elevated anterior fat pad can sometimes just be a little bit elevated just anyway, without there being any pathology. But a significantly elevated fat pad can indicate a pathology. But with a posterior fat pad, you should never be able to see a posterior fat pad. So if you can see this, suspect that there is an occult fracture. And then you also want to make sure that you're reviewing any areas proximal or you want to proximally to the elbow as well, assess if there's any fracture of the distal humerus. And then look at the head, the coronary process, and the forearm as well. Now, looking at the wrist, there are many bones in the wrist, and it took me a long time to remember every single bone. But essentially, you just want to make sure that the alignment of the carpal bones and the alignment of basically all of the bones in the wrist are, there. So with A, if we're looking at alignment of joints, you're looking at the PA view of the wrist. So you want to make sure that there is the smooth edge of the distal radius and the ulnar joint surfaces, that the carpal arcs, which you can see here, are nice and smooth, and there's no displacement there, and that there's no carpal overlap other than the pisiform and the trapezium, which are meant to overlap, which you can see here. On the lateral view, you want to make sure that that radius is aligned with the lunate, the capitate, and the third metacarpal. So we've got the radius, the lunate, the capitate, and the third metacarpal. So you want to make sure that all these are aligned. And the way that we were taught as well in university before is that it's like a cup and a saucer with an apple in it as well. So you've got the radius, which is the saucer, the lunate, which is the cup, and then the capitate, capitate, which is the apple. So the apple sits in the cup, sits in the saucer. And if there's a displacement of that, sometimes the lunate looks like a emptying out cup where it's sort of displaced forward and it looks like the cup is spilling out. So make sure that all the joint spaces are uniform. They should be around 1 to 2 millimeters in the intercarpal joint spaces, and look if there are any widening of joints, narrowing or step-offs. Bones, you want to pay particular attention to that distal radius because it's a common fracture site. Ulnar as well, especially look at the ulnar styloid process here because you can get avulsion fractures there. And then carpal bones, particularly the scaphoid, because this is one of the most common carpal fractures that you will get, and they can be very subtle and sometimes don't even present until 2 weeks after the actual injury itself, which I think we're often taught in med school quite early on, that the scaphoid is very important to ensure that you're assessing because it has a retrograde blood supply. And so if there is a fracture at the waist of that scaphoid, you can end up with something called avascular necrosis. And that's because the blood isn't able to supply the other half of that scaphoid because there's been a fracture across it. And then looking at the cortices, so you want to make sure, again, that you're tracing the cortices of all of the bones that you can see, assessing for any steps, any irregularities, which could indicate a fracture. And then soft tissue, looking for swelling, effusion, fat pad displacement, which could suggest an injury, and any calcifications or foreign bodies. And then finally looking at the hand, alignments and joints. So you want to trace every single finger, the metacarpals, the distal phalanx, all the way down to the distal tufts of the distal phalanx. You want to look for any malalignment or any joint space loss and any evidence of dislocation. The carpal metacarpal joint space should be around 1 to 2 millimeters, especially the fourth and the fifth metacarpals as well. So you want to make sure that you're looking at that. Bones, again, inspect all the metacarpals and the phalanges, and then you've got your high yield injuries, which are the ones that are more common. So you've got your fifth metacarpal neck and boxer fracture. You have your first metacarpal base intra-articular one, so like your Bennett and your Ronaldo. I was saying that anyone as well. It's Rolando. A Bennett and a Rolando fracture are unstable injuries at the base of the thumb, so the first metacarpal, and they differ in that a Bennett fracture is a two-part oblique fracture of the ulnar corner of the thumb, whereas a Rolando fracture is more severe and is more comminuted as well. So that compromises the joint more. And then you also want to check for any phalangeal avulsions at the tendon or the ligament insertions, and then consider any pathological fractures as well. Cortices, you're tracing all of the cortexes of all of the metacarpals, especially the first and the fifth, as we've said, and trace each phalanx and then look for any avulsion clues as well. And then finally, for soft tissue, you want to assess for any swelling or any indirect signs of injury. Okay, so is everyone still with us? So for our first case, we are going to do a shoulder. This is a 30-year-old male who is presented to the emergency department following a motorbike accident with severe right shoulder pain and an inability to abduct the right arm. In his history, he has had immediate onset of that shoulder pain post-trauma, marked restriction of movement, no loss of consciousness or head injury, there's been no seizure or electric shock, there's been no previous shoulder dislocations or surgery, and there's no reported neurovascular symptoms. On examination, on inspection of him, he's had asymmetry of the shoulders. There's been loss of the normal shoulder contour on that right side. His arm is held in an adducted and internally rotated manner. On palpation, he's got tenderness over that glenohumeral joint. And on the neurovascular exams, all the sensation was intact and he's got normal distal pulses and capillary refill. So with that, does anybody have an idea of what movements might be difficult for the patient? You can either turn your mics on or you can answer in the chat, whatever you would rather. I'll give you a minute or two. See, Joanna is typing. Abduction of the arm. Yes, so severely reduced active and passive range of movement. Abduction and external rotation would be particularly limited. So yes, thank you, Joanna. And what investigations would you request for this patient?
Well, given the nature of the talk, I'd probably get an X-ray first.
That sounds like a really good shout. Thank you, Lauren. Yeah, shoulder X-ray. Do you know what views we would possibly do? Got an unknown user. AP and Y view scapula. Yeah, so you would do an AP and then again you would do an alternative view. So at UHL, we try to do an axial where we can, but this patient is unable to abduct their arm. So we have a bit of an issue there. So we try to do a strip view. Now, strip views are something that I've only ever done at Leicester and I've not done where I've worked before. And we lie the patient on their left hand well, depending on what side you're x-raying, you lie them on their side that's unaffected, pop an x-ray board between the patient's shoulder and their neck, and you sort of shoot posteriorly up to that board so that you get a nice strip view of that shoulder. And it shows if there's any sort of dislocation of that of the humeral head with the glenoid. Or you can do a Y view. So this is dependent on a patient ability. If they're unable to lie on their side, if we're completely unable to do a Wallace view, which is them lying backwards, or an axial view, we can do a Y view. But you know, it depends on the protocols in the department. So yes, AP and then an alternative view as well. So here are the images that we have taken. So if I get you to just have a look at these images, what kind of things do you see and what would you suspect from looking at these images? The chat off to my side and I can see Joanna is typing. A light bulb sign. You would be very correct, Joanna. That is indeed a light bulb sign. So on the AP view, you can see a light bulb appearance of that humeral head, which suggests a posterior shoulder dislocation, and this is due to internal rotation. Now this here is a Y view, not a strip view. Usually we mark them as strip when we do those strip views. And this also confirms a posterior dislocation. You can see this adduction of the arm here as well. But there's no associated fracture identified. So when you're tracing the cortices of the bone, there's no obvious fracture that can be seen here. And the conclusion is that this is an acute traumatic posterior glenohumeral dislocation. So this is rare. It's about 2 to 5% of shoulder dislocations, and it's usually from an axial load on a flex, adducted and internally rotated arm, classically seen with things like seizures, electric shocks, or a significant trauma. So in this case, this patient has had a significant trauma. They're in a motorbike accident. So key features, they can sometimes be missed on an AP view, and around 86% have what we call a reverse Hill-Sachs lesion, or can also have a reverse Bankart lesion, and they'll need a CT and MRI. I don't know if you want to talk about this, Dr. Hussain, with the dislocations.
Yeah, completely agree, Abigail. So, you know, the anterior dislocations are the ones that we see more commonly. And if we look at the image at the bottom, I think it might take control actually, if that's okay.
Yep.
So I can use your pointer.
Moment. Yep.
Can you see my mouse?
Oh, 1 second.
I can see a mouse.
Yeah. White one that's moving, yeah.
Oh, I can see a black mouse.
Never mind. So I don't think I can. I don't think I can put a mouse on, can I? Anyway, so the bottom image there, you can see the arrow that I've placed, and it shows you the direction. So on the left you've got the humeral head, and this is an axial image. Okay, so you're cutting transverse through the patient as if the patient was lying down on a bed, and you're looking at them from the feet towards the head, and you're slicing them in that manner. So we're looking at the shoulder joint in that sort of plane. So at the front, so on the left where the arrow is, that's your humeral head. Adjacent to that, you have the glenoid, and then you have the acromion coming forward. Okay, so when we're looking at these views, whether it be an axial or Y view or any other type of lateral, you use the coracoid as your reference point to know actually are you looking anterior or posterior. Yeah, so that's our sort of our lighthouse that we always refer back to. So that's the coracoid there, and you can see the direction that the humeral head takes when it goes back. So the humeral head, where that reverse Hill-Sachs defect is, essentially abuts the posterior glenoid, and that impaction causes the groove or the Hill-Sachs to form, and at the same time can sometimes take a bit of the bone off. Now, of course, the glenoid is lined by a labrum, which is a soft tissue ligamentous structure. So sometimes when you have the anterior or posterior dislocation, more often than not, you'd have some type of glenoid labral injury, which is a soft tissue injury, which is classically known as a Bankart. And when you have a piece of bone that's taken off with it, then it's called a bony Bankart. So if it was an anterior, you'd have those two lesions in the opposite locations. So bony fragment at the front of the glenoid, Hill-Sachs lesion at the back of the humeral head. And in this scenario, where it's a posterior dislocation, you've kind of got it the other way around. Important to know that these defects can be difficult to sometimes visualize on the X-ray. Okay, the Bankarts you can usually see anteriorly at least, but with the posterior dislocation, you're going to struggle a lot. So the surgeons would normally do a CT for this.
Okay, brilliant. Thank you very much. So with regards to management, you've got non-operative or operative, and that's very based on how chronic the dislocations are. So whether there's somebody who frequently dislocates their shoulder, is dependent on the risk factors. So any bony abnormalities that they may have as well. Ligamentous laxity, so if it's a patient who has, say, Ehlers-Danlos loss, frequent dislocations, and if there's been repetitive microtrauma as well. So it's very dependent on the patient themselves as to how we manage it. Okay, so if we move on to the elbow. So here we have a 40-year-old male. I mean, he doesn't look 40. I don't think the years have been kind, but he's a 40-year-old male presenting to A&E after a fall onto an outstretched hand, or fouche, as we also say, experiencing severe pain at the elbow joint and swelling. He has reduced range of movement and difficulty extending the elbow joint. So what imaging views do we think we need? Either in the chat, or you can on your mic. AP and lateral. Yes. Okay, so if we're looking at these AP and laterals, I appreciate that they're probably quite small on your screen. So if I zoom in a wee bit and move them around. So using our ABCs, what do you think might be going on with this patient? So if we're looking at alignment, I mean, I think alignment seems pretty okay. If we look at that anterior humeral line and then look at the radial capitellar line, seems all right. If we're looking at the bones, I mean, all there. And then looking at the cortices as well. So if we come down to this one here, which I think initially is a bit better, if we follow along all of the cortexes, we're looking at the humerus. I mean, I think the humerus looks okay. Look at the ulna. We come round. And then we're looking at the radius here. So can anybody see anything going on that might indicate what is wrong with this patient? If I bring it around to this one here as well and zoom in a wee bit more. Yeah, good job. So Joanna said a radial head fracture, which is correct. So this is a mildly displaced radial head fracture, and this involves the articular surface. And it's also associated with a relatively large hemarthrosis. So when we talk about hemarthrosis, that's what we're talking about, the fat pads. So here you can see a very clear anterior fat pad sign here. I mean, I think it might be the quality of the image, to be honest, but on PACS you can obviously jim it about a bit, but yeah, and you can see a posterior fat pad sign there as well. So I think Dr. Hussain wants to talk a bit more about how we get those fat pads and why they present.
Yeah, so if you zoom into the central image with the red arrows, yeah. So this is the view that you really have to scrutinize. And we've added those red arrows there, and you can just about, if you want to point to it, Abigail, you can see the lucency that lucency, by that I mean a darker, relatively darker area on the radiograph, and that refers to the fat. So in the body, you have four densities, right? You have soft tissue, fluid, bone, and air. And the reason why we can see the different structures is because they are uh, sort of opposing each other or forming a silhouette with one another. And the difference in two densities allows you to differentiate one thing from another, from one entity from another entity. Okay, so if you have fluid in one compartment and fluid in another compartment, and they're side by side, you can't make out the separation between the two, because they're both of similar density. But if you have fluid in one compartment and you have fat in another compartment, and the fat is actually less dense than the fluid, and so you can see the difference between the two. And so when you have the raised fat pads, essentially what you have, and if you just zoom out again, if you look on the left image, the actual joint, the elbow joint capsule extends superiorly. And when you have a fracture, uh, perhaps let's look at the knee, which is a bit more commonly known at least. You have a lipohemarthrosis. So you have trauma, you have a fracture to the bone, and then the bone bleeds. And as it bleeds, it fills the joint with hemorrhagic contents. Same thing happens in the shoulder. Same thing happens in any joint. And when it happens in the elbow, and when it happens in the elbow, the joint capsule, as you can see there, distends proximally, and those fat pads, which are normally, just hugging and sitting on top of the joint capsule, are therefore elevated. Okay, and because you have fluid in that joint, you can see the difference between the fluid and the fat, and that's how you get that silhouette formed. And so as Abigail already said, if you have that sign there, then do suspect an occult fracture, as this radial head fractures can be very, very subtle sometimes.
Yeah, very subtle. Sometimes I miss them. Okay, so yeah, this is a radial head fracture, which is a very common intra-articular elbow fracture, and it could be associated with instability, a mechanical block. So that would be something, say, like an injury that's happened before, or there's something in there that's physically stopping that joint from moving properly, which could be like loose bone fragments, or any new bone formation that's in there, like osteophytes or something like that. Or a Essex-Lopresti injury. And this is a complex series of injuries which occur in the forearm, and they're usually caused by a fall from a height onto an outstretched hand. So again, similar to a fouche, and that can affect the radial head with that sort of complex series of injuries, which can sometimes break into a number of pieces. But in this case, this is a very sort of simple radial head fracture. And yeah, you want plain elbow x-rays as well. I mean, CT is useful for everything, but it's mainly useful in this case for operative planning. And then management and treatment would be non-operative if it's non-displaced and no block really. But if it's displaced and a significant injury, then you would go for surgery. Okay, so moving on to the wrist. So we have a 60-year-old female who's presented to the emergency department after falling again onto an outstretched hand. There's a lot of people doing that. And on examination, her wrist is very painful on palpation, and she has a reduced range of movement, and her wrist has a dinner fork appearance. So she was sent for an X-ray. Can we have a look at these images? What do they show if you were to interpret these images? I'll zoom in a wee bit for you as well, so you can see them a bit closer. You can either put them in the chat or you can pop your mic on and let us know. I'll give you a minute. I feel like I need a countdown clock. So we've got Colley's fracture. Okay, and yes, you would be right. So this is a transverse extra-articular distal radius fracture with dorsal angulation, which is consistent with the Colley's fracture. They also have an associated ulnar styloid avulsion fracture here as well. And the usual radiographic features of this are an extra-articular fracture proximal to the distal radio-ulnar joint. Sorry. And there will be dorsal angulation versus the volar angulation that you get with the Smith fracture. You'll get some impaction and some radial shortening with it as well, and a possible dinner fork deformity. You won't get this on every patient. And the ulnar styloid fractures they're all present in sort of around 50% or less of patients who come in with this. And they'll have a pronator quadratus sign, which if I was to zoom in a little bit here, if you see this sort of translucent line here, this lucent line here, the pronator quadratus sits in this region here. So again, when you're looking at what we were talking about before with the elbow and bleeding into that joint, what happens is that it pushes this quadratus forward and then it causes that line there. It's also known as the McEwen sign. And it can be an indirect sign of distal forearm trauma. And yeah, it relies on the displacement of that fat pad, which lies superficial to that pronator quadratus muscle. Yeah, that's that one. So with the Colles fracture, it's a very common extra-articular distal radius fractures, and you often get them with sort of little old ladies who come in with, say, osteoporosis and they've fallen on their hands. If you get them in older men, it might be an idea to investigate for things like osteoporosis with them. And with younger patients as well, it's usually from high impact trauma because obviously we have a stronger bone density to the elderly ladies. And it is often done with a mechanism of a Fuchs mechanism. But they've fallen, so on wrist extension, and they've pronated their forearm a bit. So that force is transmitted through the lunate and the scaphoid, and then it causes that fracture distally. If the fracture is extended into the joint itself, so if it's an intra-articular fracture, this is actually known as a Barton's fracture, not a Colles fracture. So it's only a Colles if it's extra-articular, so it's not communicating with the joint space. Now, a great majority of them can be managed with closed reduction and a castor mobilization. But an ORIF or an open reduction internal fixation, which is a surgery, will be considered when the fracture, if it's unstable or if the closed reduction is unsatisfactory. And I included this in here as well, so you can see the common distal radius fractures. You've got the Colles with the dinner fork, the Smith, which is the opposite, and then you've got the Barton, which extends intra-articularly. And then we got the hand. So here is a 16-year-old male who's presented to the emergency department with a swollen red right fist after punching a wooden pole. Their fifth metacarpophalangeal joint was tender on palpation, and the patient had full range of movement in their wrist and fingers, and they also remained neurovascularly intact. So they were sent for an X-ray. So if I zoom in a wee bit, can you interpret these X-rays for me and tell me what they show or what you can see? Again, just pop a wee message in the chat or pop on your mics. I think the chat seems to be the preferred method of communication, so that's fine. It's okay, I've got it next to me. A fifth metacarpal fracture. Brilliant. Also known as, does anybody else know what this is also called? Another colloquial term for it. Boxers. Brilliant. Yeah, brilliant job. Okay, so yeah, this is a transverse fracture of the fifth metacarpal with some mild radial and volar angulation. And again, you can see this best on that oblique image here that you can see. This type of fracture is also known as a boxer's fracture, which I've asked you before. And sometimes it's, you get a patient coming in with a swollen hand and then another patient coming in with a swollen face, and you're wondering what's going on. They often have a broken finger. So yeah, the definition of this is that it's a transverse fracture of that fifth metacarpal neck, and often it's caused by a direct blow with a clenched fist. So if you're punching an object. It's very common in young adults, especially males, and accounts for around 25% of the metacarpal fractures that you see. Imaging is the main form of diagnosis. So you've got your plain films, you do a PA and oblique, and it's quite important to do a lateral because that can help with the angulation and then obviously the resetting of that bone in A&E. And then also management as well. It's usually conservative. They can have a closed reduction, so they go to A&E and they put a bit of traction on and pop it back. And then they can also have an ulnar gutter splint as well, which is a big cast that goes from the forearm and then mainly encompasses the ring, so the fourth and the fifth fingers. on the ulnar side of the hand, and it has a bit of padded support as well. So it extends from that forearm to the fingertips to support the fracture whilst it's healing. And then they will have a surgical referral if there is some excessive angulation of the joint when you're looking at it on a lateral. Sorry, not of the joint, of the bone, when you're looking at it on a lateral. And if there's any rotational deformity, or if the fracture is open and there's multiple metacarpal fractures as well, they'll probably go for surgery for that. Okay, so moving on to C-spines and interpreting C-spine imaging. So I appreciate there's quite a lot of pictures on here. So if we start with the ABCs again, you want to make sure that the views that you've got are adequate. And firstly, I'd like to preface this by saying that C-spine imaging is not very often done at all now, especially in trauma. Mainly they just go for CT. However, I think it is important to look at them because sometimes you will have patients who come in, say, for follow-up C-spine imaging. We'll do things like flexion and extension views as well. But I think you've got to do a bit of X-ray with any of them. So we'll move on to CT and MR in a bit. But if we're looking at the X-rays, you want to make sure that you've got the standard view. So you've got your AP, your lateral, and sometimes if it's a trauma and you are doing X-rays, then you can do like a PEG view as well. And that can be to assess for the lateral masses and to see if there's any movement of these lateral masses here as well. You want to make sure that when you're doing any X-ray or when you're looking at any X-ray that you can visualize from C1 all the way down to C7, T1. Now, this can be very difficult in patients like your rugby players who have really stocky shoulders, and it can be quite hard to see C7 and T1 on those kinds of patients. But it's very important not to try and force those arms down because that can cause further injury. So on a lateral view, you want to assess your vertebral lines. So you've got, you've got your anterior vertebral line, your posterior vertebral line, your spinal lamina line, and then also your posterior spinous line. And you want to make sure that all of these lines are smooth and that they're continuous and that there's no break in those lines, because that would indicate that there has been movement and displacement of one of the vertebrae, or more than one of the vertebrae. On the AP view, you want to make sure that you've got your lateral vertebral margins are symmetrical. So you're looking at either side, making sure that they're nice and the same on both sides. And you also want to look at the spinous processes going down the middle and making sure that those are nice and in line as well. When looking at your odontoid view, again, it's not really a view that we do that often. In fact, I don't think I've done one for a really long time, actually. But when you're looking at your odontoid view, you've got your PEG here, and then you've got C2 and then C1. So you're looking at the lateral masses of C1 and you're looking at the lateral masses of C2, and you want to make sure that there is equal spacing and that there is no increased space in between these, which could indicate if there's like a burst fracture or something like that. Okay, so then you're looking at the bones. So you're inspecting the cortex of every vertebrae systematically. You're looking down all of them, looking at the peg to assess if there's any sort of break in the peg itself or the neck of the peg. And then you're also looking for any fractures, such as a teardrop fracture. So you're assessing all of the bony cortices of every single vertebrae. With C, for C-spine, I've used cartilage rather than cortex. So you're assessing the disc spaces and ensuring that the disc spaces are nice and even and that there's no increase in the space within that disc space. And often, especially on X-ray, the disc pathology is often not really seen, especially if there's like a herniation of the disc, and it's often down to MRI to be able to look at that if it's suspected. And then looking at soft tissues, you want to assess your prevertebral soft tissue on the lateral view. So the normal width of this, if it's above C4, it should be equal to or less than a third of a vertebral body. So you'll measure a vertebral body and see how far that is into this up here. And then if you're looking at C4 and below, it should be equal to or less than one vertebral body, so around here. And then if you can see any widening, then you can suspect some sort of prevertebral hematoma or fracture as well, which could indicate that. Okay, so the first C-spine X-ray case, we have a 70-year-old female who has had long-standing severe neck pain. And that's all you're given. So if I give you these X-rays, can you have a look and see what may be going on? Pop it in the chat or pop your mic on. Give you a couple of minutes. Oh, we have a type. Looks like a degenerative changes at the disc vertebral unit. Got Lauren typing as well. Oh, loss of joint space higher up, so maybe OA. Okay. Yeah, so I mean, there is a loss of joint space when you're looking here. You can see a loss here and a loss here. But also, when we're using our lines, so our spinal lines that we were talking about, you've got your anterior, your posterior. And if you're assessing those, you can tell that they're not smooth and that there's something a bit abnormal going on with the alignment of the vertebrae. So when looking at it like that, these actually demonstrate that there's some degenerative changes in the cervical spine, and these can be characterized by the end plate irregularity. So there's sclerosis, there's disc space narrowing, and there's osteophyte formations. So looking a bit closer, you can see that there is a grade 1 retrolisthesis of C2 on C3. So this is C1 here. You've got C2, C3, C4. So C2 on C3, this is moving backwards, so retro. So there's a retrolisthesis. And then here is a grade 1 anterior listhesis on C3 and C4. So we've got C3, C4, anterior, this is moving forward. So there's also been loss of the normal cervical lordosis. So when you're looking at C-spine, I don't know if I'm doing my pointer properly. One moment. When you're looking at C-spine, you want your lordosis like this. You want a lordotic feature, but there's been loss of that as well. And there's some mild scoliosis when looking at this anterior image as well. And there's some rightward convexity as well. So you can see this here. So if you're looking at that, does anybody know what the diagnosis could be? I mean, I've given it to you sort of, but it's a very long word. It's not that long, but it's longish. Okay. So this is advanced cervical spondylosis. And this is usually age-related, and it's a spine degeneration. They get neck pain, radiculopathy, myelopathy. It's common in patients who are over 65 years old, and it's usually more common in men. And X-ray is the diagnosis that you get the diagnosis from X-ray. Management, not much that can be done really unless it's severe. So you usually observe, and you can either have medical for the pain management of it, and then surgery can be done based on the severity of it as well. Okay, so moving on, we have this is a 35-year-old male who's presented post RTC, so road traffic collision, with a loss of consciousness and a positive seatbelt sign. So they have a Glasgow Coma Scale score of 13. What can you see on these X-rays? Now, I appreciate this is actually quite subtle, so I'll move to the one that is probably the best one to look at. I'll give you a moment. So make sure that you're using ABCs. So you're looking at alignment, you're looking at the lines, the vertebral lines, you're looking at the cortices, and you're tracing every vertebral body to assess if there is any pathology. Can anybody see anything? Joanna typing. C3 fracture. You are right. Yes, Joanna, there is a C3 fracture. Do you know what kind of fracture? If not, don't worry. That's okay. So we've got here an obliquely orientated fracture, and that involves the anterior inferior portion of the C3 vertebral body. So yeah, as you suspected, right here, you can see a tiny little fracture of that segment in the corner. And this is actually known as a, oh, does anybody know? I don't think so. I think I asked, but nobody. That's fine. So this is known as a teardrop fracture because it looks a little bit like a teardrop, I suppose. It's hanging off that corner of C3 right here. And yeah, it's known as a teardrop fracture. So, come forward. So this is a subaxial cervical fracture, and this is usually done from forced neck extension, and it can cause an avulsion of that anterior inferior vertebral body. And it's usually seen on the lateral cervical spine, which is why I zoomed in a bit more on that one than the AP. And yeah, it's usually from an extension injury. It's quite rare and it's usually stable, so it can be managed with a hard collar, but it's less severe than a flexion teardrop fracture. Classically seen at C2, but on the imaging we showed it was C3. But again, as we've said before, in reality, CT scan is required to exclude any other injuries that are going on. And cervical spine radiographs in trauma are probably not the best, so it's always really important to proceed directly to CT. And I think Dr. Hussain wanted to talk a little bit more on this.
Yeah, Abigail, completely agree. So it's a really good case because we have the X-ray which shows the finding, and if you have a teardrop that big, then you're gonna see it on the CT, on the X-ray, sorry, and on the left you can see a similar fracture for another patient who came in on one of my night shifts actually some years ago, who had a extension teardrop, and classically it's seen at C2. That's the usual level that it occurs at. But if you look on the right, so the middle and the right image, middle image is a CT cervical spine, and the right image is an MRI STER or T2 weighted MRI, which we're going to come to later, of the cervical spine. And if you had a radiograph, you might struggle a bit more with this one because you can often get small corticated osteophytes in the anterior corners of the cervical vertebral bodies, and they're of no significance really. They're just sort of degenerative. But with the CT, you can actually see that this small piece of bone fits quite nicely into that anterior inferior corner of the C4 vertebral body. And if you look there is possibly some subtle posterior subluxation of that C4 vertebral body on the one below, ever so slightly. It's come back ever so slightly. So we're glad we did the CT in this case. And when we did the MRI scan, if you look at the red arrows that I've got, they're pointing towards a bright area, which is in the prevertebral space. This is the equivalent of your prevertebral thickening that you see on the X-ray. So again, what we spoke about, you have air in the oropharynx at that level, and then you have bone, and in between you have a thin layer of soft tissue. And you can see that because it's in between two different densities. So it's between air and bone, and soft tissue is different to that. If you have something abnormal in there, then you'll get, more sort of excessive thickening of that area, which is abnormal. This is the MRI correlate of that, and this is actually hematoma or blood products in that prevertebral space. And that has happened there because the bone has avulsed off that anterior inferior corner of the vertebral body. It's torn that ALL, or the anterior longitudinal ligament, which runs along there, and as a result has caused a hematoma to occur. So what probably would have been missed on an X-ray and looked, slightly abnormal on a CT, turned out to be a very significant injury on the MRI. And if you look at the white arrow posteriorly, so if you just point to the spinous processes there, if you could, with your cursor, Abigail, just at the back.
Yeah, when I go to the cursor, it hides but here.
Just yeah. So if you look at the white arrow at the back, there's some bright signal. There's some bright areas adjacent to the spinous processes as well, and this is actually an injury to the posterior ligamentous structures as well. So in this case, we've got an avulsion of the ALL anteriorly, a prevertebral hematoma, and we've also got an injury to the interligamentous structures at the back as well. So this is quite a significant injury, and probably needs referral, or at least a review by our orthopedic colleagues.
Brilliant. Thank you. So for something that probably looks quite small on an X-ray, realistically on MRI, it's quite significant.
Other thing to note is that, don't forget to look at the cord in those, the cord signal in these areas. It looks normal there, but in such cases, always have a look at the cord, because you don't know if there's been a translational force which has, come back to normal at the time of imaging, but could have caused a cord injury at the time. Probably not the case here because we can see things are still well aligned, but just something to keep in mind.
Brilliant, thank you. Okay, so now we're moving on to CT C-spine imaging. So when looking at the NICE guidelines for CT C-spine imaging, it says that they're most commonly done for things like high-risk trauma, so RTAs or fall from heights or diving injuries. For inadequate clinical clearance, so if they have altered consciousness, they've got intoxication, or they've got distracting injuries as well that are preventing you from being able to adequately assess the C-spine. If they've got neurological symptoms after trauma, so they've got paresthesia or weakness in their upper limbs. Cervical radiographs are definitely not really that indicated in trauma because you can't really see as much on them as well. So just proceed straight to CT. And then preoperative and postoperative planning can also be done using the CT of the C-spine as well, especially if there's a known pathology. So looking at case 7, we have a 55-year-old female who is presented after having dived headfirst into a shallow swimming pool and landing on her head. So some CT C-spine imaging has been performed. What can you see? If I was to zoom in here and move a bit closer so you can have a look. If I explain them a little bit first, so here you can see the top of the peg. It's a little bit blue. And then we've got vertebrae here and the anterior portion here. So this is anterior and this is posterior. Does anybody have an idea of what's going on? Moment. Okay, so it's typing. Orbital breaking anterior arch of C1. Yes, so this is what we call as a Jefferson fracture. So yes, like Dr. Hussain said, you can see here that there is an anterior break in C1 here, but you can also see a wee fracture on the side here, a wee fracture here. So it's also known as a burst fracture of the atlas. And it's a very typical appearance of a mechanism of injury from, say, like diving head first. You've got that axial force going straight through the C-spine. You have an axial loading and it drives the occipital condyles straight into the lateral mass of C1, causing them to burst. So when you're looking, if you were to do a peg view of this patient, for example, like I explained in the first one, you would see maybe a disruption to the spacing of those lateral masses of C1 and C2 as well. So what do you think the management would be of a patient? You're going to put me out of a job. What would you think the management of this patient would be? Go on, Lauren, I saw you typing. Give you a sec. No? Okay, so you want to first of all make sure that you're assessing the stability. So you want to check the integrity of, I've got TAL here, that basically means transverse atlantal ligament. It's the ligament that basically acts as a seatbelt across the peg or the dens. I keep calling it peg, but across the dens. And it keeps it securely against the anterior arch of that C1 vertebrae. And so that prevents the C1 vertebrae from shifting forward excessively, which could sometimes, could otherwise compress that spinal cord. So you want to assess the stability of that and the integrity of that ligament. And if it's stable and it's intact, it can be managed non-operatively. And conservative immobilization can be done of a stable or a minimally displaced Jefferson fracture. With a sort of rigid cervical immobilization, so like a hard collar or a halo vest. This is to allow healing. However, if it is unstable and there has been compromise to the integrity of that transverse atlantal ligament, the patient will require surgical stabilization for that unstable injury. And that will usually be a surgical fixation. The patient will require follow-up and rehabilitation regularly, and they will require clinical imaging follow-up for quite a while, and gradual rehabilitation to monitor the healing of the fracture as well, and probably continuous imaging as well to see how that's going. And then we're moving on to MRIs. So MRI, we've spoken about it. I think MRI is pretty gold standard. You can see everything, soft tissue, bone. And it's produced based on the magnetic properties and the number of hydrogen ions in the area being imaged. We talked about physics and studying that to become a radiologist and doing some in radiography. Now, MRI was the thing that really threw me off. It uses strong magnets and radio waves to align hydrogen protons in the body. These are switched on and switched off, and disturbing the alignment of these causes protons to emit signals as they return to normal. So you switch it on, keep all the hydrogen ions lined in a row, and then when you switch it off, they all take different times to lie back down, and then the signal that emits will then produce the image based on how long it takes for different tissues to lie back down, if that makes sense. Bit more of a confusing way of doing it. If that was the way that I reminds it. I don't know if that's wrong. Dr. Hussein, you can jump in there if that's incorrect. But the signals are detected and then they're processed into detailed images, and the different tissues produce different signals, and they create different contrasts then between the structures. So what's important, I think, for us as med students and radiographers really to note is that on a T1 weighting, you have fat and that appears brighter, and then water appears dark. Whereas with a T2 weighting, water appears bright and fat appears less bright and darker than water. So the way that I remember, and I think a lot of people have been taught to remember, is with H2O. So T2, the 2 in H2O applies to water, and water is brighter. So some common indications for C-spine MRI could include things like degenerative disc disease, disc herniation, some spinal canal stenosis, any spinal trauma or cervical spine fractures, and spinal tumours or vertebral metastases as well will be included in that. So here you can see sagittal T1, where the water, so the CSF is sort of darker, and then you've got fat here, which appears brighter. And then on here, you can see it's different. The CSF is nice and bright, and then the fat is a little bit darker. So case 8, which is our final case before our wee bonus case at the end. This is a 35-year-old male who's presented with neck pain radiating to the left shoulder, posterior left arm, and left middle finger. He describes the pain as a sharp shooting pain that occasionally feels like burning. And he's noticed some tingling in his left middle finger and has some reduced sensation over the posterior forearm on examination. And it is noted that there is a weak elbow extension and a reduced tricep reflex. He's referred to neurology, who has requested an MRI of his C-spine. So this might take a little bit of digging from our myotomes and our dermatomes to try and figure out what's going on. So what can you see? This might be the better way of doing it because you can see sort of both. So if you were looking at these MRIs, and again, you can use the alignment lines of the vertebrae to see if there's any malalignment, might help. Give you a minute, you can pop it in the chat or pop your mic on. Disc extrusion, maybe. That sounds about right, Lauren. Zero confidence. No, that's really good. Well done. Yeah, so if we look here, I'll move on to the next slide because it explains it. So there is a small left paracentral disc bulge. There's one at C5 and C6. And then this has resulted in mild to moderate narrowing of that left neural foramen. So here we've got if I can zoom in. So we've got C1, my mouse isn't really cooperating there. So we've got C1, C2, C3, C4, C5. So you've got a little bit of extrusion between C5 and C6, but then you have significant extrusion of that disc herniating into the spinal canal at C6 over C7. So yeah, there's a large left paracentral disc extrusion occupying that left side. So you can see it on here as well. If I was to zoom in, you can see this area here. You can see it compressing that spinal cord in the middle. So why do you think that this patient presents with the specific symptoms and examination findings that they have? So they've got paresthesia over the middle finger and over the back of the forearm. They have weakness in extension of the elbow, and they have a weak tricep reflex. What do you think why do you think that is? And this is really digging from year 1 and year 2 knowledge. So I appreciate it's been a long time. I see nobody's typing, so I might just move on. Oh, affects the second nerve root. Okay, so the reason being is because with that large disc extrusion, it's actually compressing the left C7 root. And that C7 aligns with the clinical findings because if you're thinking of your C7 dermatomes and myotomes, your C7 allows for elbow extension because it supplies the triceps, but it also covers the dermatomes, which cover that posterior forearm and the middle finger as well. So that's why we're getting that paresthesia and we're getting weakness on the elbow extension and then wasting of that tricep muscle as well. So that explains his symptoms and examination findings. So that is the end of my cases.
Just to
Oh,
jump
carry
in
on.
before we finish. So yeah, very important distinction to make there, guys. Cervical spine, just remember the nerve roots that come out are the same, are numbered the same as the vertebra above. So C7, the C7 nerve root will exit at that level. It's different for the thoracic and lumbar spine because you of course have a C8 nerve root as well. So at L1, L2, the nerve root coming out will be L1, and at L2, L3, the nerve root coming out will be L2, and at L3, L4, nerve root coming out will be L3, L4, nerve root coming out will be L3, and so on. So at C6, C7, the nerve root that will be coming out is C7. So it's the nerve below that comes out. I think I've confused you more there, but essentially it's different for the cervical spine. An important distinction. Other thing I wanted to mention is that you know, and for some of you, you may not go on to do radiology, and if you do other specialties, especially if you do, for example, general practice, you'll be reading a lot of the reports. A distinction between a disc bulge and a disc herniation. And a disc herniation has two entities underneath that, which are disc extrusion and disc protrusion. Okay, so you have disc bulge on one side and you have disc herniation on the other side. And underneath herniation, you have extrusion and protrusion. So disc bulge is generally referred to disc entities that are greater than 25% of the circumference of the disc. And generally speaking, overall, generally speaking, are the more degenerative type of entities that occur, disc bulges. Disc protrusions and extrusions, which both come under the umbrella term herniation, are generally speaking 25% or less of the circumference and are the ones that occur acutely, you know, after lifting something heavy, doing some type of activity, and are the ones that cause that acute pain. So just to have that in your head, the distinction between the two going forward.
Thank you very much. So that's it for me, but we do have our bonus live case for Dr. Hussain to go through. So I'll move on to that now. I don't know if you have the ability to move through the slides, but if not, just let me know and I'll move on for you. Are you able to move them at all? I tried giving you permission, but I don't know what's gone on.
I can't, yeah. So this is a 70-year-old gentleman who presents to our A&E department after having some form of trivial trauma. Okay, nothing crazy, just some form of trivial trauma, but has very, very severe back pain actually. So he was initially seen, you know, the history wasn't very suggestive, but given his symptoms, they performed, you know, an AP and lateral radiograph of the lumbar spine, and he hasn't got any previous imaging at all. So I'll give you guys a second to have a look through these images and see what you think. You can perhaps zoom up the images a touch.
Is that okay? Yeah.
Yeah, that looks good. Any thoughts? You can just shout out. It doesn't matter if you're wrong. I mean, it's a very subtle finding.
I was going to say,
Osteophyte visible. Yeah. After you, Abigail.
yeah, and then I was going to say sort of, if I'm looking, we've got 5, 4, There seems to be a bit of wedging on that 4, the L4 maybe.
Yeah, possibly.
2. And then maybe some posterior displacement of 5, 4, 3, 2 of L1 and L2.
Yeah. So this thing about the discs and the osteophytes, what are we looking at there? What type of osteophyte are you seeing on that lateral? Where is that osteophyte? Is it thin? Is it big? If we look at every single
Sure,
disc,
I was looking more on the AP, so I was
maybe.
looking sort of on the laterals, but on the
Yes,
lateral aspects of the vertebrae, but
those are there too.
yeah.
Okay, so if we go to the next slide.
Ooh.
All right, so a very subtle finding, but I've just zoomed up the two images. So the center left is a zoom up of the of that X-ray, and then on the right is a zoom above the center right X-ray. And you can see actually there is a subtle cortical breach there where the red arrows are, and you can see a small gap in that osteophyte which Abigail was talking about. Okay. Now, if you look at all the other levels, they're nice, they're smooth, they're flowing with one another. But this is the only level that has a lucency, which is a relatively darker area running through the bone. Now, generally speaking, in MSK, smooth lines are generally okay. So we've got lots of these abnormal osteophytes which are along multiple contiguous levels, but they're very smooth and we're not too worried about them. But abrupt lines or straight lines, generally not okay. Okay. So here we've got this abrupt interruption of the cortex, which we're not happy about. If we look on the lateral, um, we can see that there is some lucency. I mean, it's not projected very well, but some lucency projected through that disk space at the same level, and that heightens our suspicion even more. Yeah, given that all the other levels are completely normal. And
Mhm.
then with the yellow arrows, you can actually see that the discs themselves, you can see these very thin, slender, bony um, bony areas which are bridging the gap between the two vertebral bodies along the annulus fibrosus, which is the outer covering of the disc. So
Mhm.
these are called syndesmophytes, and I don't know if many of you have heard of them as of yet, but they're a specific type of ossification that you get within ankylosing spondylitis. Yeah.
Mhm.
So ankylosing spondylitis is an entity which involves is a progressive ankylosing entity, which means progressive fusion of the spine, and can involve or can occur in multiple different entities. So you can get ankylosing spondylitis in itself, which is an entity,
Mhm.
and you can also see in psoriatic arthritis, in inflammatory arthritis, and in Reiter syndrome. And collectively, they all come under the umbrella term of seronegative spondyloarthropathies, right?
Mhm.
And they share a common entity, that is that they all have HLA-B27 positivity, which is a biochemical marker which you can test. Although
Mhm.
it varies according, the frequency varies in each disease. So, and the other thing we can see here, the black arrow, this is
Like
this
the
is
dagger
actually
sign.
that's the dagger sign, exactly, yeah. So each spinous process, when you're reviewing, should be distinct and at the level or just below the level of the vertebra from which it originates, depending on how your X-ray is angled. You shouldn't have this flowing osteophyte between those spinous processes, and that indicates that there's some ankylosis or some ossification occurring between those spaces, which should normally be um, um, lucent because they're filled with soft tissue, and as we know, soft tissue is not as dense as bone, right?
Mhm.
The other thing to mention, look at here, and when you're doing radiographs, and this is probably more for radiologists, but you're all budding to be radiologists, is something called satisfaction of search. So you'll finish looking at your X-ray or your CT or your MRI, and you'll find one or two significant findings, and you'll think that's finished. I'm done with this, but actually there's more to look at, and you have to always be systematic, and it doesn't matter what your system is. and this is so cliched, and I can't believe I'm saying this now, having had this said to me so many times before. But you have to really stick to your system. So once you've seen the ankylosis, you've seen the dagger sign, you've seen the syndesmophytes, you've seen this area which is suspicious for a fracture, and you feel like you have, I've made a great finding. I mean, you've got the significant finding there anyway, but if you look at the blue arrows in the center image, normally you should be able to see your sacroiliac joints, right? So your sacrum is that central bone at the bottom of your spine, and your ilium forms part of your pelvic bone. And in between the two, where my arrows are, you should have some lucency running along there because you have the two edges of those two bones. Now, here we've actually lost that, and everything's coming back to the original point that I made, is that radiography is based on different attenuations of different tissues in the body. If two bones are articulating with one another, the shoulder, the knee, or any other bone, the reason why you see the space is because there is something in there which is not as dense as the bone. So normally you'll have cartilage in that area. You may have ligamentous tissues, for example, in the acromioclavicular joint, or you may have other things in that. Well, they're the two main things really, which give you that density. So, when you get loss of cartilage in a knee, for example, with osteoarthritis, then you get loss of that joint space. And that's why joint space loss per se is a sign of osteoarthritis, because indirectly it signifies to you that the cartilage between those two areas has been lost. And here we can see that the bone is communicating with one another, and that's because the bones have actually fused. And ankylosing spondylitis is a disease of the sacroiliac joints as well as the spine, but primarily of the sacroiliac joints. So this is really advanced ankylosing spondylitis, undiagnosed. Perhaps a patient who's been suffering with back pain their whole life, has gone throughout their whole life. Eventually, the spine has completely fused, and at the point of fusion, there's no movement there. So if you haven't got any movement, you no longer have pain. And so he's sort of he's probably just left it as that now. If we go to the next slide. So yeah, you can see, unfortunately, this fracture was an well, we had a follow-up X-ray, and you can see the fracture's progressing, and now at that same level, there is some sort of some narrowing of that space further. And if we go to the next slide. So yeah, this is something called a chalk stick fracture. And chalk stick fractures are you can just leave it as the full slide.
Okay.
Yeah, that's okay. Chalk stick fractures are a specific type of fracture which occur in patients who have a fused spine. Okay. So what conditions give you a fused spine? Well, we've just been through one of them, which is ankylosing spondylitis, a disease which causes inflammation of your entheses throughout your body. So you have enthesial organs in your spine, you have them in your Achilles tendon, you have them in lots of ligaments and soft tissues around your body. You also have you have one in your eye as well, which is why you get the anterior uveitis in ankylosing spondylitis. So after chronic inflammation, the reparative process eventually leads to fusion of bones. Okay, so that's ankylosing spondylitis. Then you have other entities which you probably haven't heard of. I mean, diffuse idiopathic skeletal hyperostosis (DISH). It's really a generally self-limiting condition. Occurs in mid to older aged men, and can in advanced stages cause continuous fusion of bones. And then you can have advanced degenerative changes, so you can have multi-level osteophytes which can give you maybe not the whole spine fused like this case, but a segment of the spine which is fused at least. And then you can have congenital fusions, and sometimes we surgically fuse patients because one of the treatments for degenerative changes or spondylosis is to actually fuse the spine. And similar to our previous patient who'd spontaneously fuse their spine, we can sort of intentionally do that to reduce a patient's pain, because if the bones fuse, then there's no movement in there, and therefore you don't have any pain, right? And so what essentially happens is that normally you have your disc, a vertebral body, and another disc, and another vertebral body, and so on. And I'm sure you guys have probably learned about this more recently than I have, but the discs are designed to absorb shock, right? And the disc and the vertebra together allow you to have some movement in that spine, so you can flex, you can extend, and it gives you that bit of flexibility there. If your spine is completely fused, as in this case, that flexibility is gone really, and essentially it just becomes one long lever, right? And even the smallest of traumas can make that sort of very stiff and perhaps don't know how to just perhaps brittle type bone. It can cause it to snap, and as it snaps, because it's fused from anterior to posterior, it will snap in two places. So if you ever see this, if you ever see a fracture, a spine fracture in a patient with a fused spine, always get further imaging, because you may underestimate the degree of injury that we have. So our patient here, this is the same patient, so we went on to do a CT scan, and actually you can see the top middle image. The red arrows show you that fracture that we saw through the vertebral body, through the disc level. Can you just point it? And then at the back here in the posterior elements, in the interspinous level, you can see a further lucent line, which is those two red arrows pointing down, and that shows actually the fracture is extending from anterior all the way to the back of the spine. So this is from back to front, the whole thing has just fractured, because that whole thing is one big unit, right? So it's gone from a very subtle and perhaps occult fracture to something which needs orthopedic attention. Yeah. We couldn't see any displacement in this case, which was reassuring. But usually our orthopedic colleagues will do a flexion and extension view to see actually is there any dynamic instability going on here, and that will guide whether or not they want to perform a fixation or manage this conservatively. Of course, surgical treatments will vary so much depending on the center that you work in, the orthopedic surgeon who's there at that time. And most importantly, patient factors, because a lot of the time these patients are quite elderly, and the fitness for surgery needs to be taken into consideration. So just at the back, a small image there of some chalk sticks, just to show you how they break, and it's analogous to the way that the spine breaks in these cases. And on the right, this isn't actually my image, but perhaps an extreme example of the same fracture that we have, but one that's displaced significantly and is actually compressing the spinal cord there. Yeah. Very good.
Brilliant.
Next slide.
I think that's it. Huh?
Oh, very good. Okay, back to you, Abigail.
Brilliant. Well, thank you so much, Dr. Hussain, for joining us and for giving us so much information. It's been brilliant. And I hope you all really enjoyed the teaching session today. We've got our references here as well if you wanted to have a nose. It's entirely up to you. But here then we have a wee QR code for a post-session feedback form. Thank you so much.